Good afternoon and good morning, everybody, depending on where you are connecting from. My name is Benjamin Chaya. I'm a VPHI student committee member and a PhD student at the University of Amsterdam. And I would like to welcome everybody to the VPHI webinar series with Professor Alberto Figueroa.
Well, thank you, Ben, for the introduction, and thank you to the organizers of the VPH Institute for this invitation, and hello to everyone who's attending this remotely. I suppose that is good afternoon for most people, but good morning if you are in America, and maybe good evening if you are in other parts of the world. So I'm a professor of biomedical engineering and vascular surgery at the University of Michigan. And today I'm going to tell you about the research that we do in our lab. So, and the title of the talk, as you can see, is Computational Modeling Tools for Cardiovascular Disease Research, Surgical Planning and Diagnosis. These are my disclosures. And so we can just start with this introductory slide. So these slides summarizes kind of what we do in the lab, and I suppose for many people doing modeling, it's a kind of a familiar feeling. So we do a lot of data integration and combine it with simulation. So what you see here, obviously, we are focused on the cardiovascular system, and the data that we handle is several-fold, but obviously we need information on anatomy to create a computational model, and this is what you see in the middle of the slide with these aorta. But just as important, we need data on physiology. So these can be velocity and flow data that you can get with MRI or with ultrasound, pressure data that can be invasive or non-invasive, or it can be even wall motion that tells you how the different vascular structures move. And even more indirect measurements of physics, for example, perfusion or pulse wave velocity, etc. This is the kind of paradigm, summarizes the paradigm of the image-based modeling process. So you start off always with some sort of image data for the patient. Then there is a series of image processing and image segmentation steps that give you an anatomical model or a geometry. And oftentimes, the task doesn't end there. You have to map biophysical properties to such model, for example, in our case, stiffness, thickness, and things like that. And after a lot of calibration and obviously computational steps, you get to obtain a very high resolution of the physics, description of the physics. So what you see here is one of the largest models we have done. It's a three-dimensional fluid structure interaction simulation of about 100 vessels or so of the human vasculature. And here on the left, you have pressure. Here on the right, you have velocity. And in Roman numerals, you have 10 representative locations down this anatomical model where you can see the individual pressure waveforms and flow waveforms. So this is a very physics-rich information, and you can really kind of start asking questions that are relevant for your research. This is just a close-up view of the vessels in the circle of Willis, and again, the pulsating solution, systole and diastole. And like I said, so once you have these, you can really start using these tools for whatever the purposes of your research are. There's a lot of calibration here. People in the audience who do this modeling work know that you always have to convince yourself first and then others that the results that you are obtaining are backed up by pieces of data that you don't directly impose as boundary conditions in your model. So here's an example of such comparison of intermediate waveforms that we don't impose anywhere with the actual measured waveforms. So what are the key applications? So in our field, these are the four main key applications. You can use these tools to just investigate a certain cardiovascular disease. And I'll give you a few examples here. You can use this methodology to optimize the design and the performance of medical devices. This is a really hot application area where there's a lot of potentially in industry especially in industry, which is the field of non-invasive diagnostics. So here is the idea of combining imaging with modeling to maybe save the patient from an invasive catheterization, for instance, in the cardiovascular field. And then the idea that, you know, has been around for a while, but it's kind of difficult to implement. There's a lot of challenges here, the idea of surgical planning. So you can perhaps use these tools to help surgeons determine what is the most advantageous surgical reconstruction for a specific person and for a specific procedure. So I'll give you some examples of some of these application areas in this talk. So this is the outline. First, I'll cover a bit of background on vascular biomechanics. So this is kind of the basic science part of the talk, and it will hopefully help you relate to the 4 examples that I will discuss in 4 different application areas. Okay. So yeah, let's get to some background on vascular biomechanics. So the first concept I want to discuss is the idea of vascular remodeling and the fact that vascular tissue adapts in responses to changes in stress. Okay, so if you look at a blood vessel, these 3 stresses here are the main stresses that characterize the state of the vessel. You have the circumferential or hook stress, okay, that acts along the circumference of the vessel, and this is dictated by pressure. Think of a wine barrel and those rings that provide that constraint to the barrel. So this is the hook stress. Then you have on the surface, of the interior lumen of the vessel, the endothelial surface. That's where you have your wall shear stress, which is basically mostly dictated by the blood flow itself. So higher blood flow will result in higher shear stress. And then you have the axial stress. So vessels inside the body are actually under a state of longitudinal or axial stretch. Okay, you can see that because when you cut the vessel from inside the body, it's going to immediately shrink. Okay, so there is evidence that for each of these 3 forces, they are very sensitive to the mechanical loads and the mechanical environment. For example, in the field of hypertension, you can see that the vessel wall is going to thicken, going from a normotensive condition to a hypertensive condition. So this high blood pressure will increase the hook stress, and then the vessel wall is going to remodel to bring that hook stress down to a so-called homeostatic condition that the vessel is happy with. Likewise, adaptations to chronic increasing flow, for example, what you see in a fistula, you have a vessel with normal or low flow conditions that has a certain caliber, and then flow goes up again. You know, maybe you have a fistula, or you start doing some long distance chronic training, like for an ultra marathon. That's going to increase the baseline value of wall shear stress on the luminal surface, on the endothelial surface of the vessel, and over time the vessel is going to enlarge, once again bringing down that level, that preferred value of homeostatic wall shear stress to the wall. And then the last example that vascular biology experiments show you is that depending on the percentage of elongation that you subject a blood vessel to, you're going to have a significant change in collagen production. Okay, it actually has this bimodal pattern where you have for percent elongations between 0 and 10%, you follow this linear curve, and then you have a plateau. Okay. So the other concept that I want to discuss today is the feedback between global and local responses in remodeling of the cardiovascular system. Okay, so let me just walk you through this diagram. Let's say that you have, for whatever reason, an increase in blood pressure. It can be temporary or it can be somewhat permanent. You have a disease, occlusive disease such as coarctation, or you have something like preeclampsia, which is bounded in time, but some episode that elevates blood pressure. Okay, so as we saw in the previous slide, the vessel is going to remodel in response of that elevated blood pressure, and these can be simply explained by the simple relationship, Laplace's law. that basically tells you that the hoop stress will increase due to that increase in pressure. And then the best the vessel can do to bring the hoop stress down is to proliferate, to have more medial lamellar units. So this thickness H goes up, and then the hoop stress recovers its preferred value. Okay, so so that's good. That's what the vessel can do locally to adjust to the new environment. However, that remodeling results in an increase in structural stiffness, even if the fundamental building blocks of the material of the vessel don't have different properties. Just because you have more material, you're going to have an increase in structural stiffness. So that increase in structural stiffness, which is actually the product of EH, affects the pulse wave propagation physics in the entire system. So as you know, the cardiovascular system is very much a wave propagation phenomena scenario. And if you have a structurally stiffer system, you're going to have an increase in pulse wave propagation. Waves are going to travel faster and then be reflected faster. And what happens then is that, very typical with people with stiffer arteries, what you see is this transition from a normotensive condition to a situation of elevated stiffness, in which the reflective waves come back towards the root of the aorta faster in the cardiac cycle, and they tend to accumulate in peak systole. This effectively further increases the blood pressure. Okay, this is the blood pressure that the heart feels when it's pumping blood against the rest of the body. So you have this increase in blood pressure, further increase in blood pressure, which takes you again down this loop, which will result in an increase again in structural stiffness, and so on and so on. This loop here explains the process of remodeling that leads to potentially, a situation of irreversible hypertension. That it's a chronic condition. Okay. The last concept I want to explain is the importance of pulse pressure or pulsatility in vascular remodeling. I have explained what mean pressure does in terms of remodeling in the vessel wall. Now I'm gonna walk you through some animal experiments that illustrate hopefully the importance of pulse pressure. So the animal experiment here is you have this mouse model in which banding, which is basically a restriction, surgical restriction, at the top of the thoracic, at the top of the arch in the thoracic aorta. You can control the amount of restriction. And then here, the interesting thing is, if you look at the two carotids, the one before the restriction is the right carotid, and the one after the restriction is the left carotid, they're going to be exposed to very different pressure conditions. Of course, it depends on how tight you make the banding. But the right carotid, here in red, you're going to have a very substantial pulse pressure, okay, because you basically introduce a point of high resistance in the aorta. You're going to have a lot of dissipation through that banding. And then if you examine the pressure condition here in the left carotid, it's going to be much more flat, okay? So one animal gives you actually a control and the experiment itself. So that's quite nice. So my colleagues who performed this experiment, they looked at the remodeling after several weeks of leaving the animal in these banding conditions to remodeling. And so the first thing they looked at was wall thickness. What you see here is a cloud of points of thickness for different animals, for the left carotid and for the right carotid, okay? And the first thing you see, if you look at the x-axis, is that the value of thickness nearly doubled. So all the cluster points here are around 30 or 40. And here they are between 70 and almost 100. Okay, so we already knew this based on the previous slide. So elevated pressure is going to result in thickening. The interesting thing, though, is when they plotted these values of thickness against different metrics of the pressure, specifically mean pressure with the crosses, systolic pressure with the empty circles, and pulse pressure with the diamonds, what you can see here is that the index that gives you the strongest statistical significance difference between the left side and the right side is actually the pulse pressure. Okay, when you look at the p-value, you see that the cluster of points of pulse pressure for the left carotid versus the right carotid, you see this very strong correlation that is much stronger than if you look at the systolic value. And definitely, I mean, the mean value is not even statistically significant different. Okay, so we see that pulse pressure is strongly associated with wall thickening. Furthermore, if you look at in vivo axial stretch, so this axial stretch is, I mentioned this in one of the earlier slides, the amount of shrinkage that the vessel will experience when you take it out of the body. So you can see that the normal, quote unquote, carotid, which is the left carotid, has a value of stretch about 1.7, so 70% basically. And the right carotid has a much smaller value. So it's around 1.2, 1.3. So you have this reduction in coiling, recoiling, so to speak, in the axial direction of almost 50% here. Okay, so this is another sign of vascular aging. Reduction in axial stretch is something that happens naturally with age, and in this case, the animal underwent this process in just a few weeks. And just like with the wall thickness, if you look at the different metrics of pressure, the one that gives you the most strong statistically difference between the left side and the right side is once again the pulse pressure. Okay, so pulse pressure is also associated, very strongly associated with loss of axial stretch. And lastly, if you look at histology, you know, this actually brings you the ultimate insight onto what happens in these two vessels, the left side versus the right side, okay, right carotid, left carotid. Here you're looking at elastin, here you're looking at collagen. What you see is that the after 40 days, the left carotid, or the right carotid, sorry, the black diamonds, has statistically significant less elastin and statistically significant more collagen. So what happened here is that not only the vessel got thicker, the vessel stretches less in the axial direction, it's also a very different composition. You have less elastin, more collagen, and that leads to overall stiffer vessel. Okay, so very dramatic changes, as you can see, that are induced by the biomechanical loads. So with this bit of background out of the way, we can just start looking at some human research, clinical research examples that we have conducted recently. The first one is in the area, the application of aortic coarctation. Okay, so aortic coarctation is a restriction of the thoracic aorta. It's about 10% of, it accounts for 10% of the congenital heart defects, about 10,000 patients annually in the Western world. It's a congenital disease, and obviously it needs to be treated. It depends on the degree of stenosis. It imposes a very heavy burden on the heart, and it's treated, you know, sometimes surgically with a number of surgical approaches, and sometimes endovascularly. But the interesting point for us here is diagnosis. So when should you repair these conditions? This is something that is basically unclear, but the current guidelines is you insert a catheter and you measure a pressure gradient through the coarctation. And if the pressure gradient through the coarctation is greater than 20 millimeters of mercury, then, you know, intervention is granted. Sometimes in some centers, people also make these measurements under pharmacologically induced stress conditions, because the gradient might be not so big under resting conditions, but might be significantly larger under stress conditions. So the issue, though, is that even after early repair within the first years of life, and something that most people would describe as a successful surgery, life expectancy in this group of patients is greatly reduced. 80% of them don't make it past the age of 50, and many of them remain hypertensive throughout. So this is a problem in which, again, altered hemodynamic loads and vessel stiffness seem to be closely connected. So what we did here is we looked at the population of patients that had different types of aortic coarctation. So here you see the MRA of these patients, and this is the corresponding computer model. And these are just kind of, you know, data of the patient in terms of age, the type of intervention and the years since repair. And so what we did here is we did our biomechanical analysis, specifically focused on stiffness. So we use first MRI data that gives us the information on distensibility in the proximal part of the aorta, as well as in the distal part of the aorta. So with MRI here, we can understand how the luminal diameter changes over the cardiac cycle. And in this case, we also have catheterization data. So we have a wire data that gives us pressure proximal and distal to the coarctation under two hemodynamic conditions, baseline and pharmacologically induced stress. What's important to note here is that for this particular patient, you don't see a big difference between the proximal and distal pressure wire measurement under resting conditions. You see a bit of a gradient in systole, but not so, no gradient at all in diastole. This changes quite dramatically when you have a pharmacologically induced stress. You see a very clear difference between the two waveforms. And the reason this test is done is to try to unveil gradients that wouldn't show up when you are just sitting on your chair, but maybe when you're like walking or going upstairs or even exercising. Okay, so having information on area changes and having information on pressure, we can basically map tissue stiffness following some simple laws. So here you basically, in this seemingly complicated formula, what you see is that stiffness depends on the changes in pressure and on the changes in diameter. Okay, so what do we know about distribution of stiffness in the human aorta? So what we know is that for a healthy individual, the pattern of stiffness down the aorta is increasing. Okay, so this is what you see here. This is the ascending thoracic aorta, then this is the descending thoracic aorta, this is the infrarenal abdominal aorta, and the iliac bifurcation. What you see is that as you move away from the heart, the stiffness increases. Okay, and this is, among other things, the composition of the vessel changes. You have more elastin, which is very compliant, close to the heart, therefore it's compliant, and you have much more collagen when you move away from the heart, therefore you have a stiffer vessel. And obviously, for those of you that know about fluid mechanics, this is going to have a very clear impact on the pulse pressure, the difference between systole and diastole. So you see that the pulse pressure in the proximal part of the aorta is small, and as you travel down the aorta, because of this increase in stiffness, you're going to have this increase in pulse pressure. Okay, so this is what we know, that the ascending thoracic aorta is the most compliant part of the aorta for any age, actually. As we age, everything becomes stiffer, but the ascending thoracic aorta, if you're healthy, remains the most compliant part of the aorta. So let's see what happens in this patient population. So what you see here is following the methods on MRI and pressure wire, following the data, using the data on MRI and pressure wire, we plotted the stiffness for each of the patients in the ascending thoracic aorta, as well as the descending thoracic aorta. And what we see here is that in this patient group, it's the opposite trend for a healthy subject, which is all cases but one show that the ascending thoracic aorta is actually stiffer than the descending thoracic aorta. Okay, the only case that has normal patterns is patient number 7. Okay, every single other patient, you see that the ATA, ascending thoracic aorta, is stiffer than the descending counterpart. Okay, so this is a very clear indication of remodeling that these patients had, even after seemingly successful coarctation repair. And the interesting thing is, if you correlate these with the pressure gradient measurements that you could make in these patients, you see that the only patient that had basically normal stiffness in the thoracic aorta was the one with the almost negligible pressure gradient. This clearly shows you that even these other guys had quote unquote acceptable pressure gradient measurements that didn't really suggest that this patient would need another intervention. Indeed, that residual pressure gradient seemed to have a very adverse effect on the biomechanical properties of the ascending and even upper branch vessel stiffness. So this is an example of how this kind of investigation can be used to come up with better metrics to make decisions on when to treat patients and even to monitor patients. So let me shift gears a bit and tell you about surgical planning now. This is a Fontan surgery. I'll just try to describe it very briefly. Fontan patients are patients that are born with a single working ventricle in the heart, as well as a number of other cardiovascular comorbidities. As you can imagine, this is a life-threatening condition. Here you have a normal heart with the 4 chambers, and then here you have the end result of the series of surgeries that are needed to change how vessels are connected to the heart in Fontan patients. So in this patient, again, the ventricle that is non-functional is the left ventricle. So what happens is that, you know, the right ventricle in this case needs to be connected directly to the thoracic aorta, and then the venous circulation that normally would reach the right side of the heart, as you can see in this image, and then would go on to the lungs. In these patients, obviously, you can't do that, and a way to handle this, there are several ways, but a way to handle this problem is by connecting both the superior and inferior vena cava of the patient to the main pulmonary artery. So the venous return is directly routed to the lungs, okay? So as you can imagine, you know, this is probably the best you can do, but the hemodynamic conditions of the venous return and the pulmonary flow are quite different from normal patients. And these patients, you know, sometimes show a number of complications, which I'm going to describe next. In particular, just to start focusing the problem that we examine here, it seems to be critically important to handle flow coming back from the liver in a way that reaches both lungs evenly, okay? So think of flow that is coming back from the lower part of the body, venous flow. You know, we should aim for an even split of these, which naturally happens in patients with normal hearts, but in these patients, you know, it can be greatly biased depending on how these connections are made. And this is indeed one of the problems that you see in these patients when you have an unbiased flow for maybe to one lung versus the other. You see that the lung that is not exposed to enough of these hepatic venous return starts developing abnormal connections or shunts between the arterial side and the venous side. So these things are known as arteriovenous malformations, okay? Pulmonary arteriovenous malformations, which is kind of identified in this plot here. These malformations, once again, further complicate the picture of the patient because they are going to affect oxygenation quite importantly. So you're going to have flow, deoxygenated flow that comes down the arterial side. It's supposed to reach the alveoli to, you know, dump CO2 and get oxygen, but it never completely does so. Instead, it gets shunted through these AVMs and then goes back to the heart without having been properly oxygenated. So in these patients, you see that they have typically very low oxygen saturation, and they even have higher than normal cardiac outputs, because the other bad thing about this problem is the fact that it induces shunts between arterial system and venous system, and you have basically a path of low resistance there. So it's a relatively common problem in a certain group of patients that have interrupted the inferior vena cava. And the interesting thing is that when surgeons identify patients with these issues, it usually happens when they are teenagers. What they are trying to do is to redo the connections in a way that flow coming back from the liver reaches both lungs equally. That's basically what their target is in these surgeries. Okay, these are just a few publications that illustrate this problem. So this is the case study that I want to present here. It's a 19-year-old female with severe right lung pulmonary arteriovenous malformations. So you can see that the right lung to your left looks quite different from the left lung on the CTA. Very low oxygen saturation, 82%, dextrocardia, a number of other issues. Okay, so so these patients usually have a lot of data that is something you can really use in your modeling. So here you see the CTA. We can build a computational model, and we have data on flow and pressure almost everywhere. These patients get followed and monitored quite a bit. So here you can see the phase contrast MRI waveforms in almost every vessel. You see that it has the elevated cardiac output and a very biased flow towards that right lung. So almost a factor more than 2 to 1, double the flow goes to one lung, and that's the one that has the arteriovenous malformations. Again, that path of flow persistence. So we were contacted by our cardiac surgery colleagues, and we were asked to assist with a optimal surgical planning for this patient. So in surgical planning, there's really 2 steps. First, the first step is really to produce a virtual surrogate of the patient. Sometimes people refer to these as a digital twin, but to us really is about calibrating a model such that it reproduces all the data that we have for the patient. So we're going to have data on anatomy, data on flow, data on pressure, and you need to put it all together to create a computer surrogate that really describes or matches what you know about the patient. And this is really what takes the longest. And once you have that, and only after you have that, then you really move on to the step of surgical planning. Okay, so what you see here is, you can, the surgeon can tell you, well, I was thinking about a couple of different options for this patient. And then what you do is, following how those 2 options look like, you modify your calibrated model and explore the performance of each of the options. So this is a step 1. So this is the end of calibration for this model. So what you see here is a pressure and velocity, and here you see comparison between data, which is in the dashed blue line, and simulation. Okay, so here you're looking at RPA flow, and this is the catheterization data for the other pulmonary artery, the left. So whenever you see, in our case, whenever we see these kind of overall match of mean values and pulsatility, we are happy, and we say, okay, let's move on to the actual surgical planning component. So in this case, the surgeon obviously is the one who tells us what they're thinking about doing. Consider 2 different approaches. One is sketched here, is the option 1, which is labeled hepatic thoracic. So the idea here is to remove this vessel that was suspected to feed only the left lung and none of the right lung, and this is the one that really carries all those hepatic venous return. So remove it from there and then connect it, surgically connect it to the azygos vein. So then hepatic venous flow will come this way, then up, then come down this way. There's some kind of complex mixing here, and it would divide up between the 2 lungs. Okay, so the other option, which is labeled Fontan to inanimate, same thing. We're gonna redo this shunt here, and it's gonna be detached from the left pulmonary artery and then passed over the aorta. So this patient has dextrocardia. That's why it looks this way. So you move it over and then connect it to the inanimate vein, and then the hepatic flow is gonna come back this way and then down this way, and again some mixing here and division. Obviously, it's impossible to tell what the split of the flow between 2 lungs is gonna look like unless you actually calculate it. So once you put everything through our modeling workflow, this is what you see. So in the first solution, we ended up, we can eventually reconstruct perfusion, and we can see that in the first solution, we have an 80-20 split of hepatic flow going to the right and left side respectively. And the second solution was a bit more balanced. So it's a 70-30 split going to the right and to the left. When you do modeling, you have information, the ability of getting into hemodynamics in a much more insightful manner. So the other thing that we did is, to calculate these perfusion maps, we basically inject particles and then we see where they go. So we wanted to see how the distribution of particles will vary depending on what point of the cardiac cycle you injected. And here you basically see that in the first solution is highly variable over the cardiac cycle, highly variable depending to the point of injection, whereas in the second solution it's much more predictable and constant. So that's the reason we went with this second solution. So that was our recommendation, the Fontan to inanimate. So they went ahead with that. And in the day of the actual surgery, so what they did is they did a pre-operative angiogram that really shows when you go with a catheter and release your contrast agent here, you see that indeed all the contrast agent goes to one lung, indicating that none of these flow makes it to the right lung. We kind of already knew that. And this is the actual surgery. So what you see here is our computer prediction that shows a lot more of the flow from that vessel going to the right. And so after they are done with the reconstruction, that kind of matches what we had done. They inject the contrast agent again, and now you can see that it actually reaches both lungs, which was the goal of the surgery. Okay, so you see perhaps even more contrast agent here than here, kind of matching our predictions. So this was a kind of a good story, successful case, and a follow-up. The patient's systemic saturation had greatly increased, indicating that exposing that pulmonary bed to hepatic flow would kind of do the magic and start closing off those AVMs. Okay, and this is an example of most of the examples that I'm showing you here today actually are examples of research done by clinical fellows in our lab. So let me just skip this. Let me just shift gears and show you another example of surgical plan, in this case done in adults. You know, and this has to do actually with thrombosis. So in this case, we are looking at a case of a 80-something-year-old lady with a thoracic aortic aneurysm. Okay, and this lady had to undergo a series of steps really in fixing this aneurysm. So what you see in step B here is the result of open surgery in which a graft was sewn into the ascending part of the aorta to fix the aneurysm. You see a bit of a kink there that was a bit worrisome. And then at a posterior follow-up, you see how there was another growth, aneurysmal growth, this time in the top of the arch. Okay, and this was then addressed with an endovascular procedure. So you can see the stent graft in there. Okay, and then 3 months later, when the patient came back, the cardiac surgery team saw that the patient had actually developed a thrombus, which is kind of this dark lump that you see here and up here. So this is obviously very worrisome. Bits of thrombus can get loose in there and travel to the brain and give the patient stroke. So the surgical team wanted to understand why it happened and if there's something that could have been done to change this outcome. Okay. So in this case, what we did is we built a computer model of the actual geometry of the patient that you see here. And then a number of alternative scenarios that are either redos on the surgeries or maybe something that could have been done differently. So what you see here is, okay, you know, we suspect that that big kink in the surgical graft in the ascending part of the aorta greatly disturbs the flow, so it could be a trigger for thrombus formation. So what if we go back and we straighten it out with another surgical repair? Sure. I mean, I think we all understand that this might make things better, but of course, it's another open surgery in an elderly patient. So, you know, something to really think about. The other alternative is, okay, you know, there's another very substantial kink in there in the top of the arch. So what if endovascularly here, this is something you could do endovascularly, you put a cuff in there that maybe smoothen or soften that tortuosity. And then the last example was actually a very interesting one, which is when the TEVAR, when the thoracic endovascular repair was done, the left subclavian was kind of closed off and connected to one of the upper branches surgically with a bypass. So that's another thing that you're changing in normal hemodynamics in the thoracic aorta. So the cardiac surgeon asked, what if I had used a fenestrated device that preserved the left subclavian without further altering the hemodynamic conditions there. So this is the kind of what if questions that you can ask with modeling, right? So this is what we did. We look at each of these scenarios, okay, using again the information that we have about anatomy, flow, and pressure for these patients. And in this case, you basically look at the 4 different scenarios that I showed you in the previous slide. And what I'm going to show you here is an analysis that involves releasing hundreds of thousands, almost 1 million particles here in the flow stream that was calculated for each of these scenarios. And for each of these particles, we calculate the history of mechanical shear as they move through this flow. Okay, so this is an index that we call platelet activation potential. And what we see here is these, again, massless particles moving over many cardiac cycles, okay? And the color map really means high, red is high, so the more mechanical shear experienced by these particles as they navigate through the flows, through the bloodstream, the higher the value of these index, okay? So once, the simulation kind of reaches some sort of steady state, what you see is that for the actual condition of the patient, this is again the actual anatomical condition of the patient, you see a very high value of this PLAP precisely in the region where the thrombus created. Okay, if you look at this case here where you don't address that kink and you simply take care of that distal folding, nothing really changed. Maybe this is expected. If you look at this case here, maybe also in a way that you could expect, if you straighten out and make the flow much more well behaved, so to speak, in the ascending order, so you straight out that kink, the value of the PLAP greatly reduces, so you have a lot less shearing of the flow. And what was really interesting here is to see that the case in which, even in the presence of the kink, if you had preserved that left subclavian, you basically have one of the main outflows in the thoracic aorta still active, and you would actually greatly reduce the shearing history that particles in the thoracic aorta have. Okay, so this really shows you once again how insightful some of these simulations can be in order to understand altered flow dynamics in this case in surgical repair. And this is again another example of a paper that is done by an MD in our lab. So let me just move on to the last example here, which is also related to thoracic endovascular aortic repair. And in this case, kind of closing the circle, we're looking at the remodeling consequences of these repairs. So TEVAR, thoracic endovascular aortic repair, has become the treatment of choice, as you saw in the previous example, for descending thoracic aneurysms due to the beneficial outcomes over surgical repair. Back in the day, 10, 15 years ago, it would be an open chest procedure. Now it's something that you can do endovascularly with relatively minimal incisions, deploying a catheter that has the device. And what you do is you end up having a new passage for blood flow that shields the weakened aneurysm wall from that high blood pressure. However, the design of this endograft has a number of issues. The main one is that these devices are much, much stiffer than the native aorta. They need to be stiff for deployment purposes. I mean, you're basically crimping these devices into these deliberate catheters, but they are very, very stiff, even when you compare them to the aortic tissue of hypertensive patients. And as you know by now, aortic stiffness plays a very significant role in cardiovascular disease research, disease development and progression. So some studies recently have shown the importance of these stiffness mismatch between TEVAR and the native aortic tissue. So in this study, we wanted to quantify precisely the impact of TEVAR-induced aortic stiffening on the left ventricle in terms of stroke work and mass. So remodeling on the left ventricle. Okay. So for these, we use patient-specific fluid structure interaction analysis. We measure left ventricular mass from echocardiography and ECG-gated CTA. And for each patient in the study, we have 2 time points one right before TEVAR, and two after 1 year follow-up. Okay, so what you see here is this patient population. So these are 8 patients, 6 female, 2 male. Mean age was about 68 years of age. Here you see the pre-TEVAR scan. These are the 8 different aneurysms. You can see very different shapes. And then this is the post-TEVAR scan, okay, where you see for each patient the stented aorta. For the computational approach, you have to do a fluid structure interaction analysis. Again, here you see the pre-TEVAR and the post-TEVAR. And the important thing to note here, if you look at the color map, is that the stent graft itself is about 50 times stiffer than the native aorta. That is a huge difference there, okay? So as you can imagine, this is going to really affect the compliance of the conduit compliance of the vessel, and it's gonna impose the, you know, heavy burden on the heart. Actually, it's not occlusive, but it's just the total lack of compliance that is going to potentially do something to the heart. So in terms of boundary conditions or modeling approach, we have obviously 3D Navier-Stokes for the aortic part. And then we use lump parameter models, different circuits that are relevant for different parts. So 3-element Wink Kessel for the normal outlets. And then we have the, you know, coronary boundary conditions and a heart model with patient-specific tunable contractility, so the elastance. We have hemodynamic data on blood velocity with Doppler, as well as pressure measurement. And we use these data to calibrate our heart models on a patient-specific basis, basically, specifically the contractility, okay, through these elastance function, okay? That basically tells you about the pressure-volume relationship. So these models are calibrated, again, to match the clinical data for both time points, pre and post. And here you see the different waveforms. And the interesting thing here is that with this approach, we can calculate the pressure volume loops of the heart. And so these pressure volume loops are given in the pre and post time point for each patient, okay? So the pre is in red and the post is in gray. And what you can see is, and this is again, calibrated to match what we know about the patient. What you can see is that there was an increase in 25% in left ventricular work. The area within the PV loop is work, and you can see that, you know, particularly in the post scenario, the systolic pressure tends to be higher than in the pre. But most importantly, for our purposes here, the area inside the curve of the PV loop is, for this population, 26% greater. So this is telling you that the heart is working harder, okay? It's doing more work to get blood into the system. And the really interesting thing is when we looked at the morphology of the ventricle. So we took morphologic measurements and confirmed an increase in left ventricular mass going from the pre-scan to the 1 year follow-up. So you can segment out the area of the myocardium, and you can see that for this particular patient, the heart muscle went from being 87 grams to 106 grams, okay? So it's almost a linear correlation with the increase in stroke work. So the heart is pumping harder, and then it got proportionally bigger, okay? So here are the correlation functions between these left ventricular mass index and the stroke work, as well as the left ventricular mass index and the mean blood pressure in the post and pre cases. So what we see here is that TEVAR for descending aortic aneurysm is associated with a 26% increase in left ventricular stroke work and about the same increase in left ventricular mass during follow-up. All of these patients need intensive antihypertensive management to control blood pressure. And you know, there's a very clear indication that we need more compliant devices. We need better devices that can mimic the natural function of the aorta so that we don't put this additional burden on the heart. And again, this was another paper that the main author was a clinical fellow. We have an ongoing prospective version of this study. What I showed you was using retrospective data at our institution, but we currently have an ongoing prospective study. And we also have a published protocol in the British Medical Journal Open, so that people in other centers can potentially look at the way we measure things and how and what techniques. So we gather information potentially in the future in more centers. Okay, so just to conclude my talk, there is a clear link between altered stiffness, hemodynamics, and hypertension. Animal models suggest that pulse pressure, and not just mean pressure, is a big driver of vascular remodeling. In the problem of aortic coarctation, it seems like residual pressure gradients following seemingly successful repair result in likely irreversible remodeling of the upper body vasculature. For TIVA repair, there's a clear need to design more compliant devices. And going back to our turf, computational modeling and imaging can be combined to assess hemodynamic indices with a level of detail that is not possible with imaging alone, and to get insights into disease development and planned surgeries, even non-invasively. I want to finish by having a word to the software tools that we use in our lab, and this is basically what we develop. Everything you saw here is not used, it's not done using commercial software. The name of the software tools in our lab, which are open source, is Crimson. That stands for Cardiovascular Integrated Modeling and Simulation. And so when we started this project, our vision was to integrate best-in-class open source standards for cardiovascular simulation. So you know, we obviously have a very heavy focus on the solver. We rely on MITK for medical image visualization, and we have our flow solver is available in the American Heart Association Precision Medicine platform through AWS. We have libraries for data simulation, open source mesh generators, and so on. And so this kind of gives you an idea. This is a little bit of an older slide, but it gives you an idea of the traffic that we have both in the US as well as in the world and Europe. So I want to finish by acknowledging my funding sources and my clinical and engineering collaborators. And thank you again, the organizers, for giving me the opportunity to present here at the VPH webinar. And I'll be happy to take any questions if you have them.
Thank you very much for a great presentation, Alberto. We do have one question right now. Somebody posed in the question box, and it's from Cristobal Bertolio. He was wondering, in the AWS coarctation study, he wasn't sure if you said if the stiffnesses were computed using rest or stress data, and if you have a reference for this study.
The stiffness, yeah, that's a great question. The stiffness were calculated using the resting conditions. And yes, there's a published abstract on this work that I would be happy to send the information for. Yeah, this person is very good question. The stiffness will obviously depend on the level of pressure. So if you look at hemodynamic conditions under stress, you will get different values of stiffness proximally and distally. But I remember that the patterns were the same in the sense that if you see a pattern of larger stiffness in the ascending versus the descending at rest, is going to be maintained at stress, with the caveat that stress conditions are usually, the data for stress conditions is usually more noisy. So, you know, maybe you can't trust those measurements as the ones you acquire under resting conditions.
Okay, he asks for the question, do you expect the ratios to change, like in pulse pressure?
They could potentially change, yes. Again, the main issue here is the fact that it's difficult to give the same level of trust to the measurements under stress conditions and resting conditions. There's a lot more hemodynamic variability and just the challenges of getting the data under stress conditions. So it's a difficult question to answer, but the ratios could change potentially, certainly.
Okay, thank you. So there are a number of other questions, but at the moment, I'm just going to go through scientific questions and then we'll go through practical questions later. So I see one from Pim van Ooy. He asks, you use FSI, but can you use time resolved meshes? Is it possible, and would there be an improvement?
So if I understand the question is, you could not solve fluid structure interactions and instead prescribe the motion from dynamic data. However, that defeats the purpose of much of the research that we're trying to do here, because we want to really solve rather than impose the structural component of the work. So it's important for us to gain insight onto what happens in the system when the properties such as stiffness change. So if you kind of eliminate that component by directly imposing motion, you're not going to be able to get the kind of insight that we're trying to get here. So I hope that answers the question. It is possible to do, but for stiffness research, I think it's key to keep this FSI approach.
Okay, thank you. We have another question concerning FSI. So it's from Oscar Camera, and he first would like to thank you for a great talk. He would like you to comment on the additional value of 3D FSI simulations with respect to lumped models on the Fontaine pre-planning case. Also, the use of 3D printing for preoperative planning.
Yeah, so I think in the Fontaine case, the end goal really is to understand the differential perfusion of those hepatic factors between the left and right. So that's something you can do with a lump model. I mean, it's something that only a three-dimensional flow field will be able to give you. There are other instances where reduced order models certainly can be the way to go, compared to the much more expensive 3D approaches. So the other question regarding the 3D printing, I mean, as he knows very well, 3D printing is something that is used widely in the area of congenital heart disease because the surgical reconstructions that these patients necessitate in very complex geometries are very, they benefit a lot from being able to gain these highly detailed three-dimensional reconstruction of these vessels to plan optimally these procedures. So yeah, simulation and 3D printing are fields that are very complementary in congenital heart disease.
Okay, thank you. So I see one more is a technical question on the Crimson package. Sanjay, I'm sorry for the last name, but Karchi, I will try my best to pronounce that. He asks if there's any support provided for potential Crimson users.
I mean, support is a vaguely defined term. So we have a growing user mailing list where people post questions, and I see that for the most part they get answered mostly by our team members, but sometimes it's kind of refreshing to see how new users actually answer questions of other users. So support of software support in an academic setting is it's a difficult thing, right? I mean, you can't do it like like Microsoft can. That's an understatement. But we've tried our best to answer questions through our mailing list, through our user groups on Google, and I think for the most part, people end up getting an answer.
Okay, thank you. We had another scientific question roll in. This one comes from Eduardo Prurito. He asks, have you coupled your models with 4D PC MRI data in order to compute the stiffness of the wall? Which is your opinion about the 4D PC MRI data?
Yeah, so that's a question that we got in our forum quite a bit. So we have the ability of directly prescribing 2D phase contrast MRI as inflow or outflow boundary conditions. So the short answer is no, but it's something that we have the building blocks to do. I mean, coupling is, again, you need to really define exactly what you mean by coupling. Having 4D flow data, of course, can be very useful to have a kind of model-wide insight onto flow splits and outflow boundary conditions and so on. So if you can process your 4D flow data, subsampling it to have two-dimensional planes, it's something that you can do already. And then you can maybe combine it with our Kalman filter capability to maybe assimilate some of that 4D flow information for your simulation. And then the last part of the question, obviously 4D flow is getting a lot of use in terms of derived hemodynamic quantities like pressure gradients, relative pressure gradients, and even some wall shear stress. So, as it gets better, faster, and less noisy, I think it will have a lot of applicability and specifically a lot of synergy with CFD approaches.
Okay, thank you. We have two more. This one comes from David Ox, and he asks if there are ways to deal with added mass instabilities in Crimson.
So, I mean, that's a very technically deep question. All of the results that I showed here are with linear elastic models, and we almost always use a external tissue support, which consists on specifying both elastic as well as viscoelastic properties that simulate the behavior of the surrounding tissues and organs. This is something that provides stability, not so much numerically, but for your solution. If you don't use it, and if you have complex turns and thin vessels and so on, when you solve your pulsatile solution, you will see a lot of fluttering in the simulation. So it's quite important to get these external tissue support conditions. So yeah, it's something that we use routinely, and we actually have a couple of papers where we kind of investigate a report on the impact of these different values of external tissue viscoelastic constraint, if the person wants to check them out. We have developed nonlinear shell models recently, and we haven't quite started to explore the corresponding behavior of this external tissue support under those conditions, but we will be doing that in the near future. So yeah, it's a great question, something that you need to pay attention to, certainly.
Yeah, thank you for a very detailed question. I know sometimes with numerical simulations, I mean, they can go quite technical. So we still have two more. They keep coming in, which is great. That's a very interactive webinar. This one comes from Alessia Barretta, and she asks, how much manual work is there with respect to the automatic one performed by the software? Do you believe in the future this may be a decision support system to put in the surgeon's hands, or would you always need an engineering supervision along with it?
Yeah, another great, very insightful technical question. Thank you, Alessia. So obviously, on the research perspective, from the research perspective, we want to eliminate manual workflows and subjective. Everything is somewhat subjective, but manual. So I can comment on two aspects. So on the geometric reconstruction, part of the reason that we went with MITK, we didn't know at the time, but it ended up being a kind of a good decision, is that MITK has recently partnered with NVIDIA, and they have now a version of MITK that contains an SDK from NVIDIA with the name of Clara. And that SDK is something that would allow deep learning for segmentation in cardiovascular images. So our process in segmentation is now mostly manual, but there's a lot of research that is being done on establishing neural network based pipelines for geometric segmentation. So, you know, the future will be more and more something that relies on these kind of automatic operations. On the area of boundary condition specification and material parameter specification, we do have these Kalman filter capability that if you have appropriate time resolved data, it can estimate the parameters of your model automatically. So, you know, the short answer is right now in our lab, still a very manually intensive setting. But I do think that if someone wanted to create a workflow for surgical planning that is automatic, it is in not the too distant future. I mean, we have the building blocks for that, and maybe this is something that can be taken as a you know, kind of a big project, but a doable one.
Okay, thank you. There is 2 more questions. I mean, they keep getting asked. So here's one from Julio Sotelo from the Universidad Valparaiso in Chile. And he asks, how is the FSI simulation affected if we generate the model in a diastole or a systole cardiac phase?
Hello, Julio. Yeah, that's another great question. So, the short answer to that is, if you have different diameters, you will potentially have different structural stiffnesses. So, you know, obviously, to have the full picture for stiffness behavior, which is going to affect the behavior of the FSI, you have that. If you think of that, you know, EH parameter, material stiffness times the thickness, it's the product of those two that affects the structural behavior. So if you create a model that is gated towards systole versus diastole, and you make approximations on the thickness of the vessel that are according to that baseline diameter, that's how it's going to be affected. Of course, physically, we know that in peak systole, the thickness is going to be a little bit smaller than in diastole, but this is something that you can't really measure easily. So, you know, the issue of stiffness is just a tricky one. I think we know the behavior from first principles, but there's definitely some challenges in measuring the data. So, but I mean, physically speaking, your stiffness is going to be ever so slightly higher in peak systole than in diastole.
Okay, thank you. This last question is a little lengthy, and I apologize. It's really the interface here doesn't allow me to see a lot of text at once, so I'm going to try my best at reading it. So this one comes from Julian Vega Aduen. He has a question regarding shear stress. He asks, is oscillatory shear stress a more strong marker of a hemodynamic burden, giving better prognostic information than the wall shear stress alone? Yeah, because nowadays to prescribe surgery in aortic aneurysms, we only rely on diameters, which are a very gross predictor of aortic rupture. So may this be in addition to hemodynamic markers that will aid deciding surgery in patients?
Yeah, another great question. So I think couldn't quite hear, but I think, Ben, you said oscillatory shear stress, correct?
Yes, correct.
Yes. Yeah. So, yeah, from a vascular biology perspective, I think there is evidence that shows that situations of disturbed flow and flow that is not mostly unidirectional, for example, in the abdominal aorta, have been correlated with aneurysm formation. So you can certainly see how a situation of oscillatory flow will potentially be associated with increased permeability in the endothelial cells. They tend to be way less packed and aligned with the direction of the flow. So that can be associated with the beginning of the increased permeability and inflammation in the aortic wall. So I think there is a trend in the cardiovascular field towards moving away from purely anatomical or morphometrical metrics to make decisions. For example, in the field of aneurysms, just the diameter, and go towards more physics-based metrics that can give you a bit more insight into what is happening there. No, it could be occlusive disease, it could be aneurysmal disease. So the challenge here is the variability, the lack of consistency between studies. But I do believe that these kind of more physiologically rich indices could play a role in making in stratifying patients, maybe risk stratification, and maybe even making decisions in the foreseeable future.
Okay, great. Thank you very much, Alberto. So that, I think, brings most of the scientific questions to a close. I do see a handful of people that asked if there were slides available or a recording available. I just want to repeat that the whole webinar, all the audio will be recorded and put online on the VPH Institute website. So there you can rewatch the entire recording of this webinar. So I would like to just thank you one more time, Alberto. I mean, this is a really a well-attended webinar. So I think, yeah, thank you very much for your great talk.
You're very welcome. Thank you, Ben. Thank you, Martina. And thank you, everybody, for making it today. Thank you for your questions. And I hope everyone is doing well. And hopefully I'll see you in some conference when we are all able to go back to those meetings in person.